Good morning and welcome everyone to today's session. The session is titled A Rural New York Healthcare System's Response to COVID-19 and the New Plan Forward. We have two representatives today from Bassett Health Network. First, we have Dina Charles, who's the Senior Director of the Primary Care Service Line and Center for Innovation, followed by her colleague Henry Knoop, who is the ACMIO Medical Director for the Center for Innovative Care. So with that, I'll go ahead and turn it over to our speakers. Dina?
Yeah, thank you so much for the introduction. Appreciate it. If you'd like to just we'll go to the next slide. There are no disclosures for either Henry or myself. Next slide. And so we want to start off by giving you an outline of what we're going to be discussing today. We're going to be providing you information and background about Bassett and who we are as a healthcare system. What we were doing pre-pandemic and our state of telehealth overall as an organization, what we put into place as a response to the pandemic, to COVID-19, and what our future state looks like post-pandemic, and what are some of the lessons learned from this situation that we could take it and push forward in our future for telehealth. Next slide. So who are we? Bassett Healthcare Network is almost the size of Connecticut. So we span 8 counties in the middle of New York State. It's 5,600 square miles. As you can see here on the little map that we have here placed on the PowerPoint presentation, all those blue dots indicate all the different locations where Bassett is in our square mileage. We have 5 hospitals. We actually have 6 EDs, 90 primary care, school-based health, and specialty clinics. So although we are rural, we have a lot of locations. Next slide. So as far as our telehealth history, we have been doing a little bit what we call dabbles in telehealth over the last 20 years. We had a lot of previous efforts in telestroke. There was a lot of grassroots efforts for Bassett to develop a more comprehensive telemedicine program. We started really pushing it 2017, but due to some project management turnover within our organization, by 2018, we really kind of flatlined. Our school-based health centers had written a grant and received that grant funding and still have it for telemedicine services in that program. And then by 2018, in the fall of 2018, Henry and myself were assembled as a telemedicine team, which evolved into what's called our Center for Innovative Care, which was formed last year. But it's grown exponentially since that point in time, and we'll kind of share with you what we've done as an organization to grow our telehealth initiatives. Next slide. So pre-pandemic state, I believe, Henry, this is the part where you're going to jump in, so go right ahead.
So we really want to outline where we were before COVID. Before COVID, we had received a district grant in 2019, and that was really to lay the infrastructure down for our telehealth initiatives at Bassett. It was really to get the framework going so that we could roll more services out when we were ready. From when we received the grant in early 2019 through pre-COVID early 2020, the following initiatives were launched. We had telestroke and teleneurology available for inpatient consults, teleneurosurgery for inpatient consults. We had post-bariatric surgery video visits to patients' homes, ambulatory, teleendocrine clinic set up as outpatient, telepulmonology for inpatient consults, teleprimary care, that was clinic to kind of disperse evenly the need for care, telepalliative care, that was inpatient consults for end of life, expansion of teledermatology, which was done both inpatient and outpatient, so outpatient telederm clinics as well as inpatient telederm clinics, consults. We established a teleneurology movement disorder clinic for outpatient. We implemented a dispersed teleconvenient care project, which really let our convenient cares that are kind of walk-in urgent care clinics, one might be really busy, one that might not be. We were able to see patients via telemedicine from one clinic to the other, which really helped with numbers. And then tele-integrated behavioral health, which was done in-house with counseling and psychologists. On top of that, we also developed an e-consult program last year that went live in the fall. We pre-COVID had dermatology, endocrine, pulm, urology, cardiology, ortho, spine, GI, wound care, and infectious disease all live. And for those of you who don't know what an e-consult is, that's actually something we have set up so that our primary care practitioners can send an e-consult instead of a referral to, say, dermatology, and they can send pictures with it. And we can actually bill for those services when the dermatologist reviews it, lets the primary care practitioner know what their recommendations are, how they would treat it if they need a biopsy. And this all gets done normally within 24 hours, but we put a timeline of 72 hours on it. But we've actually seen really good turnaround times. Patients are getting care much faster, and we're able to bill for that care and avoid people waiting months to get in for some of our specialty services. So that's been another very successful program pre and post pandemic. Next slide. These are our volumes. It's good to take a look at kind of what pre-COVID was. We were really proud of ourselves pre-COVID. We had no idea what we were in store for, but the ambulatory visits for 2019, through all those programs, we did just under 4,000 visits. And in 2020, just in January and February, we had done over 1,000. So we were on pace for over 6,000 visits ambulatory. And then our inpatient consults, we did 637 in 2019, and we were on pace in 2020 to do just under 1,000. So we were really starting to ramp up with that infrastructure, roll out new programs. And I have some little bit of visual aids that I'll go over in the next slide. So this is, we like to have a document where you can really see what we have live and what we're working on. We try to break it out by service. So we have our telemedicine visits on the left. Those are everything that's live, actual video visits. We have our e-consults, everything that was live, and then our school-based health centers. We offer the concussion screening, telepsych, teledental, and pediatric care in our school-based health centers. And then we can go to the next slide. These were all of our projects that we had planned to work on in 2020. So we're actually still working on an e-visit program. We were really looking to expand our convenient care. So not only did a patient have to walk into a convenient care and get seen by a different convenient care by telemedicine, they could walk into their own health center in their community. And if there wasn't a visit available, we would be able to just do the convenient care visit right there at that clinic. Expanding primary care service line, really expanding outside of our medical center and our network to outside community-based organizations, trying to get wound clinics up in nursing homes, post-surgical check-ins in nursing homes or the patient's house, developing more outpatient clinics, really expanding those e-consults. We have a really robust medication-assisted treatment for opioid use disorder here at Bassett. We're looking to get that done via e-consults and some of our other subspecialty areas that really need better access to care here at Bassett. Okay, next slide. And so that was our plan, and then COVID hit. Now I'm going to let Deanna go over our pandemic response.
So, obviously, as everybody knows, the pandemic hit and everybody was in a state of what do we do now? So just to kind of break down what we did and how our response worked, in February, we kind of started to anticipate this. We started having some preliminary discussions and began some planning. By March, we had started setting up some stuff that we'll talk about a little later, really tried to provide some community education. We were starting to do some COVID testing, not as in a large scale, but starting to do it small scale in trying to establish some evaluation processes. And we actually put into place an RN triage system that we'll talk about 24/7. By early April and early May, we completely redesigned our outpatient with telemedicine, and we'll talk about that on the next slide. We established these evaluation areas and screening tents at several of our health centers, as well as tents outside of our EDs. We also did some redesign in our inpatient, which Henry will be touching base on, regarding in our negative pressure rooms and kind of some new team structures, both in our ICU and our PACU. And then by late May, we started ramping back up as an organization, trying to get back to, operating at this new normal, but beginning to bring our patients in and bring our patients in safely and, looking forward to the future. And telehealth has been a big component of a lot of this work as we move forward. So next slide. So, when we were evaluating our pandemic response, a lot of healthcare systems, had a lot of things to prepare for when we were planning things out, planning for a potential ICU surge. We are in New York State, but we are fortunately in the middle of New York State, so we didn't see as big of a surge. We had a small surge, but nothing major compared to our downstate colleagues. We had an increase in the ambulatory no-show and cancellation rates, as I'm sure everybody kind of faced. Patients just didn't want to leave their homes. They're instructed to stay home. They didn't think it was safe to even go to see a physician. There were shortages across the country for PPE, and there was a lot of protocols that had to be put in place. Can we reuse? Can we not? Do we have enough to see the patients that we absolutely need to see? Both staff and patients had a lot of anxiety, going through this process. And I think there's several people who still have that anxiety. And restrictions for visitation in our inpatient clinics and our outpatient clinics were put into place. Even nursing homes, we do have some affiliated nursing homes with our hospital system, and the same thing happened there. But what really didn't change, and still hasn't changed throughout this whole pandemic, is that patients still require care. People didn't stop having diabetes. People did not stop having CHF. They still need care. They still needed to be seen. Especially our mental health patients now more than ever really needed that support and that pipeline. And so we really leaned on telehealth and telemedicine services to really help guide us in that effort. Next slide, please. So we're going to talk about our different elements to our pandemic response. And I'm going to have Henry first touch base on what we did on our outpatient or in our inpatient side. Go ahead, Henry.
Sure. So we, as a rural healthcare network, we only have one true ICU with 14 beds, and we only have 5 intensivists. And we quickly realized before the pandemic even got to us, and we started seeing our hospital admissions go up because of it. We quickly realized that we couldn't afford to lose a single intensivist. So what we did, the first and third bullet here kind of go together. But we established a tele-ICU very quickly. It was kind of a makeshift ICU. We had Surface Pros and laptops on carts in every room in the ICU, in every negative airflow room in the hospital and our affiliate hospitals. And also we turned our PACU outside of our OR because we were no longer doing our surgical procedures. We actually turned our PACU into a COVID positive ward that was fully outfitted with telemedicine equipment. And what that equipment really helped with, in the negative airflow rooms, because we had patients who were PUI or COVID positive, is that it allowed the nursing to check on the patient regularly, which our protocols was every hour for anybody who was COVID positive. The nurse didn't have to use PPE. We set these devices to auto answer, so it would ring once and let the patient know that somebody was about to connect to the computer. But the nurse didn't need to put full PPE on just to enter the room and see if the patient was okay. They could do that, obviously, if they needed to go in and the patient was uncomfortable or needed something, but at every hour, we were going through PPE rapidly. Also, our ICU doctors, we established a room actually outside of the hospital in one of the admin wings of the hospital, outside a patient care area. And that's where the ICU attendings were set up so that they could go and actually round with our teams. We had medicine and surgical teams rounding on all of our COVID positive or PUIs and everybody who was intubated. And it was nice because we had pre-COVID trained up everybody on those teams so that the ICU doctor could actually take a look at the ventilator and give advice on how to change the settings, and they were all capable of changing the settings. So it actually allowed people to round on the patients without using PPE to enter also. And, something that we really took a lot of pride in and we heard a lot of positive feedback around was that patients' families were able to connect to these patients via video and visit their loved ones in all of these rooms. So we weren't able to put a Surface Pro or a tablet or a computer in every room in the hospital, but we were able to put one in a lot of rooms in the hospital and still have families be able to connect with their loved ones. And actually a lot of them still be present in end of life situations that we had, a fair number of. I'll turn it back over to you, Deanna.
Mm-hmm. So during this process, we also recognize, as we said earlier, patients still needed care on the outpatient side. So over a 2-week period, what was once just a one specialty project where we were doing integrated video visits in our EMR, we expanded that rapidly over 2 weeks to every single outpatient department that we had, both primary care and specialty, to allow them to schedule telemedicine visits integrated in what we use as Epic. It happened very rapidly. I can't say that it went off without a hitch. There were certainly some glitches among the process and a big learning curve. One of the positives I can say throughout that process is, practitioners who at one point in time have talked about telemedicine, but were, not really positive about it or a little leery about doing telemedicine services, they actually very quickly adapted to this process, were very open to doing it, more willing to do it now more than ever, because they really wanted to still have that connection with their patients. And so they found it to be very important. So in 2 weeks, we did rapidly deploy it to all of our departments. We also had established a hotline for both our patients as well as for our staff to call to get real live in the moment technical support to help them work through the glitches that might occur during connecting with a patient. As we know, it's very challenging for patients to connect from home. And a lot of times there's uncontrolled variables that we can't control, but we wanted to make sure that there was an opportunity for patients to call one phone number to get real live support when they needed it. We also established staff and practitioners working remotely. One of the things pre-COVID that we never really thought about is having, practitioners and or staff, say a front office person who answers phones in a clinic to work from home. COVID really forced us to think differently as we were looking at social distancing and, the need for people to really physically be in the buildings. So we really leaned on telemedicine to really have our focus on having safe environments for our staff, but to also allow people to still work. So it's funny when we were doing this, I never thought that I could have front office staff working from home answering the telephone and hitting the button, but the systems are designed to allow us to do that, fortunately, here at Bassett. And so we found that we have staff working longer hours and better hours for our clinics because they have this capability, following up on referrals, catching patients, working 12 to 8 instead of the normal 8 to 5 because it works for them, but it also works because we're having better connections with our patients and getting calls back to them, after those normal 5 to 8 hours. So it's really interesting. It's really made us relook at things differently, but COVID forced us to do that. The external evaluation sites and tents. So as I mentioned, we put several external evaluation tent locations at a lot of our health centers. And so what's interesting is same thing theory we have with the inpatient side is we have telemedicine cards placed both in the ED as well as in the external evaluation sites where we can still listen to heart, listen to lungs, and use those peripherals, but they could be seen by a practitioner via telemedicine. So there's a nurse there, they could use the peripherals and check these things for the practitioner, but the practitioner is available via telemedicine. And again, it's very helpful in terms of trying to lower our utilization of PPE when you think of the volume of patients that are going through our evaluation tents. For us at Bassett, these evaluation tents, they still exist today, and we're using these tents to evaluate patients who have upper respiratory symptoms or symptoms that, the CDC warrants as potential COVID symptomology. So it's been very helpful for us to limit our PPE usage, but still see these patients safely and keep our staff safe as well. We did also implement a COVID-19 system checker questionnaire. We use this right directly on our website where patients were able to, or non-Bassett patients were able to go to our website, click a button, answer some questions, and it would prompt them based on how they answered and responded to the questions if they would require further evaluation or not. If they did require further evaluation, it gave them a phone number to contact. And that phone number was to our 24/7 COVID-19 RN and APC triage line. That actually, again, still exists. We do have what we call our 5555 number, where patients or non-Bassett patients, we treated everybody as long as they were within our 8-county radius, They could call, they would talk to an RN, they would be triaged, and if they screened positive for a COVID screening, that would then go to a practitioner who could then see a patient and send them a link and see them via telemedicine to determine what the next course of action should be. Should they be scheduled at an evaluation site? Are they okay? And that it's not something related to COVID, but medical decision making could be made in the moment via telemedicine with a practitioner. To date, we've done over 9,500 triages on that triage line, and it continues to be in use today. Next slide. So in terms of the volume that we've seen, March and to date, we've actually conducted a total of 32,732 visits. And we've also done over 18,000, almost 19,000 phone visits. So as Henry kind of alluded to earlier, you know, we weren't that much higher. We were probably, you know, on pace for maybe 6,000, and we rapidly in a couple of months significantly increased our volumes because of COVID-19 and our response to COVID-19 using telemedicine and telehealth methods. Next slide. So this is just a graph to show you kind of our percentage of in-person visits versus telehealth. As you can see in January and February, you know, it was very minimal. It was about 0.8% of the total level of services that we were providing. March, it started to tick up, but by April, 51% of the visits that we had in our outpatient settings were done via telehealth or telemedicine versus in person. And as you can see, as we're beginning to ramp up, it still is a very important factor in terms of how we're going to deliver care safely to our patients, but it has significantly decreased. What we're finding is that we are now getting patients comfortable enough to coming into our clinics. So, you know, there's different ways to use telemedicine. I believe Henry will be talking about that shortly, of kind of how we see the future of telemedicine fitting into the ways that we deliver care. Next slide. Oh, this is our survey. So we also found it very important to solicit feedback from our patients about how is their experience with telemedicine, as this was really widespread and rapidly so quickly to all of our patient population. We wanted to see what they thought of it and how they felt the sessions were going. So every patient that had a video visit received a link in their what we call our MyChart account with Epic, and we gave them the 4 questions that you see below. And they were rating it between very, very poor all the way through to excellent. And on the next slide, we'll show you actually what our results were. So we received almost 3,000 responses. And as you can see in the results for each question, overwhelmingly positive. And it was interesting because when we read the comments, obviously you saw there was a comments portion, and we read through all the comments. And even for patients who maybe had a problem or a glitch with technology, maybe they clicked the link wrong, maybe their internet just wasn't working, and that video visit resulted in an actual phone visit, they still rated it as an excellent experience. And the appreciation from our patients that we were able to provide this type of care to them and still willing to provide them care during this difficult time, it was very much appreciated, and we saw it in the comments from our patients. Next slide. So this is a very busy slide. So as you saw previously, we showed you kind of pre-COVID, we showed you, you know, what we were looking at in terms of our 2020 goals. As you can see in the teal bluish color document that's on here, those are what we did as our COVID response. So some of these things that are in yellow as future projects, some we have done, some we are still actively working on at this very moment. But the teal are the things that we did still during the COVID response. And next slide. So I'm going to let Henry talk about what our post-pandemic future is and what we're going to do moving forward from our lessons learned.
Thank you. So as you saw, we rolled out a lot of new technology in a short amount of time. And we learned a lot. I think everybody that I've talked to about telehealth within Bassett and outside of Bassett is just blown away at how much we learned and how much patients have adapted and practitioners have adapted, especially ones that we did not think would adapt previously. Some of the successes that we had, our behavioral health department is still our most utilized for telehealth. And they were one of the most skeptical pre-COVID to roll over to telemedicine. they are still doing 78% of their visits via telemedicine, and they've decreased their no-show rate from 10.7 to 8.6% overall. So we're seeing less no-shows. The patients are very happy with the behavioral health care that they're getting via telemedicine, and the practitioners they really love it. They some of them don't want to see patients in the clinic anymore. They just want to do telemedicine, which is not surprising. That's what we told them pre-COVID. But we've seen decreased travel time for our specialty providers. Being a rural healthcare network, some of our specialty clinics are located over an hour and a half away. So now that those providers have established these teleclinics, they're seeing more patients because they don't have to travel that time to these remote locations. We're also incorporating follow-up planning with telemedicine. So when practitioners are choosing their options on how the patient's going to follow up with them and when they're going to follow up, we're giving them the option to tell the front end staff that's going to schedule that follow-up appointment whether the patient's appropriate to be seen via telemedicine or in person. That helps us. I think as telemedicine was rolled out rapidly, it was really a process of combing the schedule to see, okay, who can we roll over to telemedicine? And it takes that step out of the way. If the patient can just be scheduled for telemedicine, they know ahead of time their visit's going to be done through their MyChart app, and it actually will increase our numbers long term and incorporate that telemedicine element into our care here at Bassett. We did a lot of development on that patient portal. It's called My Bassett here. It's MyChart through Epic. And we really want to continue that going forward. The development of that portal has been excellent. The feedback we've been getting from patients is they just want more now. Now that they're used to using it, they want more. They want self-scheduling. They want more questionnaires. They want a couple other things. So the last thing is the continued surveying to make sure we're meeting the demands of the patient. We had 3,000 responses, and I think of those 3,000, 1,900 of them gave a comment. And overwhelmingly, they wanted this to stay. They didn't want it to go away after COVID. They really liked having that ability to see their practitioner via video in a much faster time frame also. Next slide. So the challenges that we face are no different than what everybody's probably facing, and probably some good topics for discussion and kind of what we've been talking to other people about in neighboring healthcare networks is, one, finding the right combination for in-person video visits. Initially, we'd said, okay, we know in April, we're doing 52% of our visits via telehealth. What's the right number? And I don't think there is a right number. We'd come up with our clinical leadership and operational leadership to have a number of 20% as the goal. And it's really hard to just have an arbitrary number or a goal of we're gonna hit this number, because every practitioner is different, every department's different, the way they use telemedicine. So what we've been doing in that second bullet there is where to use video visits in every department. So we're starting to set up meetings with our chiefs and our operational leaders to figure out who's traveling throughout the network, who's seeing these patients at these rural clinics outside of our main campus, who can we convert over to telemedicine clinics, and then also what patients are appropriate in your subspecialty to be seen via telemedicine for their follow-up visits. Is it the person calling for a medication refill? Is it the person who came in for shoulder pain that you did a full assessment on them and sent them for an MRI? Do they need to come back in 2 weeks to see you if the pain's better, or can that be done via telemedicine? So it's really figuring out with every department what the best patient type is for telemedicine, and then trying to incorporate that with them. The other challenges, are the same challenges we had pre-COVID. The uncertain payer landscape with COVID came a lot of new regulations for reimbursement and parity, payer parity. That has been great, but just the uncertainty of not knowing what's going to be the landscape going forward is tough to build a telemedicine, offering around. You can build it, but if it's not going to be paid for in 3 months, it's really hard to devote resources to that. The regulatory landscape for place of service. Is the home going to be covered as a place of service going forward? The covered services, annual wellness visits done via telephone, done via telemedicine at the patient's home, is that going to be allowed? The Office of Mental Health has put a lot of, loosened a lot of regulations regarding telemedicine. Is that going to stay? Is it going to go? It's hard to build programs around stuff that was so successful in COVID without knowing if it's going to be here going forward. Next slide. So we did want to give some facts about Bassett Telehealth. The platforms that we use, we support both Zoom and SwiMed. SwiMed is a company that we started integrating with. They were the company that our school-based health centers actually started with. We started with an integration with Zoom back in 2017, and then we ended up switching that over to SwiMed last year. So we do offer SwiMed and Epic integrated visits for ambulatory video visits to the patient's home. Our electronic health record is Epic. I will also add for the platforms that we had a fail-safe. So if our integrated system did not work via SwiMed, we had everybody download the Doximity app, and we had a lot of success with, if the first time trying via telemedicine did not work, instead of going directly to telephone, we would see if the patient could get text messages and had a phone with a camera, and we would hop on Doximity and send them a link to text message right through there. And Doximity was really successful for us for keeping those visits via video for us to bill. We offer video visits for hospital to hospital, clinic to clinic, clinic to home, home to home. So we're offering video visits across the board. Like we described earlier, we're offering e-consults for practitioner to practitioner consultations. Structurally within Bassett, the Department of Telehealth falls under Bassett Center for Innovative Care, which was established last year. And that's comprised of our Chief Medical Information Officer, Dr. Scott Cohen, our Associate Chief Medical Information Officer, myself, our Senior Director of Primary Care, Deanna Charles, and our Telehealth Coordinator, Haley Kyoto. Next slide. So what we've learned through this process, I think it's good to kind of look back and say, if you're looking to build, if you haven't built a platform out, or you're looking to build one or expand what you have, kind of what we learned through this process, you really have to have a solid team that leads the telehealth initiatives. It's better if these people are devoted to the projects full time, but having proven leaders within your organization make up a team that devotes part of their time to this also works. Our team, with Dr. Cohen, myself, and Deanna, we all have obligations outside of telehealth, but it's nice we have time carved out to devote to telehealth also. And it works really well. And having our coordinator, Haley, devoted full time to this helps a lot. Your telehealth team really needs to be tied in closely to 4 things within your organization: clinical leadership, operational leadership, finance, and IT. It is imperative to have that. We have monthly meetings with all of those groups, but we also have open dialogue all the time with those groups. It's really hard to get any project off the ground unless you have all 4 of those departments in your organization signing off on it. So we've been really lucky that our organization has said, we're going to offer care digitally. So we're going to work with this team to make it work. I know that's not the same everywhere, but you really have to have buy-in from those 4 places within your organization to really thrive doing this. You need to identify where you want to go with telehealth, and then you need to really take a deep look at the vendors and platforms that align with your goals and budget. There's a lot of companies out there that offer telehealth platforms and services, and I just saw that chat pop up.
We'll talk about that. We can talk about that after. Yeah.
It's really important to make sure, figure out what you can build in-house, and then see what you can't build in-house, and really get an RFI from a lot of different organizations and see if they align with what your goals are.
We built our own carts. We elected to build our own carts from a budgetary standpoint. It made sense that we could get everything we needed with customizing our own carts ourselves.
Yeah. So some of the vendors we looked at for platform, we had to buy the carts through them. Some of them that were very expensive. And a lot of times those carts would only run their program. We couldn't run anything else. If we decided to switch platforms in the future, those carts were essentially useless. And that really just didn't align with us. We weren't looking to kind of, dive in with one place and know that we were never going to change with them. So being flexible was important to us. And I think that really helped us with this COVID response. Speaking of budget, look for grant money that is available. We would not be doing all of these visits if it wasn't for our initial grant that we got a year before. So we were, not to say lucky before COVID or when COVID hit, but we had done a lot of infrastructure build that really allowed us to turn it on within 2 weeks. Had we not done all that infrastructure build, it would not have been nearly as successful as it was for us or as easy to support. Listen to your patient population, doing surveys. We have patient representatives on a couple of our committees, and it really helps steer where we're going when we say, this would be great if you could have this, and they look at us and shake their head saying that they would never use it. You really have to listen to those patient representatives. You need project management support. We have a project manager, Sandy, who is phenomenal. Without her, it would be really hard to keep everything on track, especially with Deanna, Dr. Cohen, and myself all having obligations outside of telehealth. It's kind of hard to make sure you're staying on track with everything, and having that available with project management support is really essential. And lastly, don't underestimate the IT resources needed to get a telehealth project live. This could not be more true, especially in the era of electronic health records. It's really hard to do any of these projects, especially integrated projects where you're not going to have to lean on IT heavily. The way our structure's set up with our CMIO and our ACMIO both being involved in telehealth has really helped us, because we're that link between clinical leadership and our IT department. And it's been really nice having us, because that link with the IT department has really helped us as we go through projects with IT and ask for resources that are going to need to be allocated to build within our EHR. It's been really nice, but don't underestimate how much you're going to need those IT resources. Okay, next slide. Okay, we can get to questions.
Okay, great. Thank you guys so much for this presentation. We did have a few questions. As you can see, we've popped it up on our Zoom here. So we'll start from the top down to the bottom again. I didn't get a chance to introduce myself in the beginning, but I'm Natasha Manzanera. I work at HRSA, Office for the Advancement of Telehealth. And so I'm actually the project officer for the Northeast Telehealth Resource Center and the Mid-Atlantic Telehealth Resource Center. And I believe Bassett also has a project officer on the line as well. So we have about 28 participants that have dialed in. So really great to see the interaction and the folks that have joined us today. So well, the first question, can you talk about building your programs out by service modality and how linear of a progression it was for departments?
You want to take that one, Henry?
Sure. So, initially when we had gone through pre-COVID on how we were going to build out these programs by service modality, that we were looking at a couple things. One, what was the need? So when we formed the Center for Innovative Care, we had a lot of requests. So we actually made a request document for departments to fill out of, if they wanted to get telehealth involved with in their department, how it was going to happen, who was going to be the practitioners. It was actually pretty in-depth. Was any hardware needed? Where the budget was going to come from, all the questions that we knew we would get asked, as we brought these proposals forward. So that was our plan. And, as far as each department, some were into telemedicine, some weren't. We really weren't going to force people into telemedicine if they didn't want to do it. So we had this planned approach. And then with COVID, we really rolled it out. It was really hard to roll it out within 2 weeks, because we rolled it out to everyone. We just turned it on. We had one video visit built and we just gave it to everybody. And it was easy to support in that manner that we gave one visit to everyone, but it was hard to support because every department functions differently. So normally we like to go to that department. We like to see how they operate, kind of develop their telemedicine solution for them. And that just wasn't possible. So we rolled it out really broadly. And, I think it was really good because it forced people that weren't comfortable with it to become very comfortable with it. And the requests that we've had now going forward has been exponentially increased because people are comfortable with it. So can you go back to the question? Sorry, let me just make sure I'm answering. I think linear was, it was a straight line up for the progression for how the departments were rolled out. Do you want to add anything to that, Deanna?
Yeah, just because of the urgency with COVID. So pre-COVID, to Henry's point, it was kind of the department sees how telemedicine can support the department and enhance the services that they're providing. They give us a request, we evaluate the request, we determine when we can fit it in from a project management standpoint, and then we would, put it in the timeline, let them know, work with them, partner with them, and make a project happen. COVID basically forced, at least from a ambulatory setting standpoint of seeing patients in their homes and practitioners being home or in their clinic, we turned it on for everybody. We educated everybody that it was coming. We did a lot of training. We had a lot of ongoing support, but it was basically, it's available to every outpatient setting. So we had a plan and progression based on what the department saw, how it could help them and where they saw it fitting and what they wanted to do, versus everybody has it available now. Now it's everyone has it available. How do we see it fitting in, to Henry's point earlier, into the services that they're providing? So, and how they want, one of the things Henry didn't mention, but in one of our clinic buildings, we have a lot of congestion in our bullpen where all of our providers document and stuff. Their office isn't right in the clinic building, it's actually in a separate building. So a lot of them would do their, notes and documentation in this same small space. Well, with concerns with social distancing, we see telemedicine as a means to separate that bullpen area so that there's not people congested. We could social distance safely, and having telemedicine days in their offices such that we're making sure everyone's safe, but we're still getting the patient's needs and care taken care of. So, it's that we're on to that next phase, but it was, unfortunately with COVID, it was kind of, it wasn't a straight line. It was just kind of up. So, but it's been working out very well for us.
Okay, thank you. So we have another question. As a rural location, to help the patients who have lack of access to technology and bandwidth, are you partnering with any other community systems such as libraries, schools, etc., to give patients an opportunity to still visit their specialists that are far away?
So we haven't really reached out to community systems, but it's funny, we had this conversation with IT probably 2 weeks ago, and we're putting in another grant for something very specific to this. We weren't really partnering with community systems, but being a rural healthcare network, we have clinics in just about every medium to larger size community in our catchment area. Like we said, we have 90 clinics. And 2 years ago, if you were to say, hey, do you really want patients sitting out in your parking lot using your Wi-Fi? We would say, no way, we don't want patients sitting out in the parking lot using our Wi-Fi. And now we're actually putting in for grants to expand our wireless access points so that we can offer Wi-Fi in our parking lots. So most patients have a Bassett clinic somewhere in their community or in a community very close to them. So offering this technology where they would be able to go to just a Bassett clinic, we have over 90 of them in our catchment area, and be able to pull into the parking lot, access our guest Wi-Fi, which we then know is going to be able to support a telemedicine encounter, and actually have them be able to do their telemedicine visit there. It's kind of our model, but that's a good idea to reach out to libraries, schools, things like that.
Thank you. So for the next question is, I'm amazed by the number of similarities in our institution's response to COVID. We have actually been using a separate telehealth platform to date, but are actively engaging in a pilot phase of an Epic-based platform and are very excited to see how it goes. I wonder if you can speak to your experience using Epic-based connection as compared to what you were using previously.
You want me to take this one, Deanna?
Yep, go ahead.
Sure. So, we really, really like having the integrated visits within our EHR. It is very seamless. The patients have a MyChart account, so they get all the instructions. We've custom built all that out. so that they get instructions on how to do their video visit. There's a link right there for them to test their device, whether they're logged in on their phone or on a computer or a laptop. They can actually test their device, make sure their video works, make sure their audio works. It's seamless. We can control when it opens up before the visit, how long it stays open, when it registers the patient and checks them in. There's just a lot of things, a lot of small things that when you're rolling this out, you have to think of, that we really, I think we kind of thought on the fly. I think initially we thought, oh, it'd be great to have this integrated, so the provider just has to click one button and go into the video visit. But there's been so many other small things that have been benefits to having an integrated solution for these video visits. I think it's very specific to each institution also. We had issues with Zoom, and I know a lot of people use Zoom. We've talked to a lot of other institutions that use Zoom as an integrated model and unintegrated, and a lot of them are very happy. Our security protocols are pretty high, and we had issues with Zoom. They just did not work well. I think it was about 1.5 years we went through the integration process, and it just did not work out. And had it worked, it would have been completely fine. When we switched over to SWIMED, I think it was a 6-week process, and it's been working fine ever since. So I think, I would push people to do the integrated solution if it's available. It is more build. It is, a lot of decisions to make on that patient-facing side, and also how it connects on the back end, and a lot of the front end registration decisions. So you need to have a lot of people engaged, but when it works, it is a very, very good solution.
I would just like to add, though, it is also important to have a backup plan. Unless you have 100% engaged in your portal, you need a backup plan for patients who just simply don't want it. So what we like about our platforms, SWIMED, we have it both as an integrated version, and we have an unintegrated version of it as well, where we can email link to the patients. Or if they don't want to do it via email, we can use Doximity. So that is our go-to model in terms of how we're delivering the telemedicine. But again, you got to have a backup plan.
So I actually want to continue on to the similar question regarding the Epic platform. So on this question where it says, additionally, how has it worked with MyChart requirement for the Epic-based platform, specifically for pediatrics where a parent holds the proxy access to the child's MyChart?
Go ahead, Henry.
So this came up. I mean, this is a real problem that every single institution is going to face. Luckily, we were able to work with our Epic TS and our privacy department to come up with some solutions. So what we did is actually we allow a pediatric patient with a parent with proxy access to be able to launch that video visit until the age of 12. And at the age of 12, that's when all the restrictions come in for proxy access to pediatric patients' medical records. At the age of 12, the parent and the patient have to, make sure that that patient has their own MyChart account with their own login. And that is what we use for our telemedicine encounters for the ages of 12 to 18. So very real problem that everybody will face.
So on the same vein as for patient portals, so the question we have here is, we've got extremely low utilization for patient portal systems statewide, and would be interested to hear how you had success getting those into use.
So I can talk about that. So with obviously doing the integrated visits and flipping the switch for all the departments, obviously we needed to get patients linked up to our Bassett or MyChart account for patient portal. So there were several things that we did. First, we actually ran reports of patients who were not either received a code to activate and never activated, or weren't activated at all. And so we had a team of individuals, because our clinic utilization was down. We took those staff and had them start cold calling our patients to try to get them enrolled in working list of patients to get them enrolled. We also instituted a call-in line, a MyChart call-in line, where patients could call in and troubleshoot and get linked up and set up right away. So we would direct patients, if we didn't connect with them on the cold call, to call that call line so that we can get linked up to our MyChart account. Also, when we're calling patients and we were setting up their appointments, we would say, okay, in order to do a telemedicine encounter, we want you to enroll in MyChart. And we would, because every patient right now, we still do this, we are actually calling and doing the pre-registration process over the phone. So during our pre-reg process over the phone, we would talk to the patients about MyChart and the benefits to using it and getting them enrolled. Additionally, another thing that was helped us really engage our patients in MyChart activation was actually the results from COVID testing. So in our evaluation tent sites, we would let patients know that if they signed up for the Bassett or MyChart account, they would get a quick response on their test results if they were negative. We actually had it set up in the system such that if it was a negative result, the result would immediately go to their MyChart account. If they were positive, they would be receiving a call from a practitioner, but it would be the quickest way for them to find out whether they were COVID negative or not. So that really helped us too as well. Those are some of the things that we put into place to help us with our patient portal systems. I could tell you that our growth rate now is higher than it used to be. If you look at the patients that we have scheduled right now, we're at about a 63 to 65% of the patients that are scheduled today have a portal account, which is higher than where we were last year before COVID, which we were running, I think, about 30%. So that is a much higher rate now than we've ever had. And we're going to continue to push that forward. We still have the hotline for support and continuing to try to enroll our patients.
And I'll add, we tried not to let any inpatients leave without being signed up for MyChart.
Yes.
So we created reports to run on our inpatients on who did not have portal access set up. And we had some of our front end staff from clinics that were, may have been shut down or had less volume, actually rounding in the hospital with an iPad to set patients up with MyChart so that they had it before they left.
Mm-hmm.
Great. We have about 7 minutes or 8 minutes left, so I think we can try to answer the rest of the questions here. So would love to hear about your telehealth and telemetry adaptations for nursing homes in your network and role in reducing ER visits.
Mm-hmm.
So this has been a plan of ours since we got our grant in early 2019, is to really branch out, especially to our affiliate nursing homes, but also to all the nursing homes within our network. And we have just recently started our first big push out to nursing homes. That's telepsychiatry with actual medication management and counseling offerings to one of our affiliate nursing homes, and it's going extremely well. But we have a ton of requests also for the main purpose of reducing ER visits. We have our chief nursing officer here at the medical center who really wants to get the call set up, because every nursing home, especially our affiliates, has somebody who's on call overnight, a practitioner that if a patient spikes a fever or they fall or something, and the majority of the time when the nurse calls from the nursing home, that practitioner is saying, okay, just send them to the ER. And most of the time these patients, at least in our rehab facilities, we're just in the hospital. So, that patient coming back is a big ding for us that we try to avoid. And, we're not trying to keep patients out that need to come, but we're trying to keep the ones that don't need to come, because we have a lot come to the ER. They say, you're fine, do this, and send them right back to the rehab facility or nursing home. So we're actually pushing to get telemedicine set up. Whether that goes to an ER practitioner or a convenient care practitioner or just our on-call practitioner is still to be determined, but that's the goal, is to actually be able to do, complete overnight telemedicine visits from a nursing home to one of our practitioners for the purpose of keeping those patients that don't need to go to the ER out. But we're also looking at a lot of other services too.
Yeah, I was going to say rehab, that's a big thing too. We hear all the time, nursing homes, the cost of getting a patient for a follow-up while they're in rehab after they just had a surgery, and the time it takes to do that and the discomfort for the patients. Whereas we'd rather use telemedicine, that's a bundled service as part of the surgery. It's a no charge visit, essentially. It's part of the bundle. So why not do that via telemedicine in the comforts of where they are, so that they don't have to travel to a site, because we are rural. It does take a while to get to our location from our affiliate nursing homes.
Thank you. The next question is, any thoughts on scheduling considerations for your provider's average day in regard to ratio of face-to-face versus video visits as you move forward?
I can take this one. It depends on the department. Like Henry said, 80% of the visits are being done via video in behavioral health in our Department of Psychiatry, for an example. I can say in primary care. I'm guessing just based on what we're seeing right now from a percentage base, I think 90% of our visits are going to be done in person, and about 10% are going to be done via telehealth. I think in other specialty areas, I think it's going to be, the rate's going to be a little bit higher, because I also think we're seeing a benefit where we could see more patient volume mixing in these telehealth visits versus all in-person visits. So I think it's going to be a combination. I think time will tell what the perfect ratio is going to be as we are in our ramp up phases for those other divisions. But I think, as Henry mentioned before, you got to take into consideration whether you have travel, you have to take into consideration whether you have social distancing as a mechanism, or whether or not you have practitioners who have to work remotely. I could tell you, we have practitioners who go to that are snowbirds who go to Florida in the winter, and they provide primary care full clinics 3 days a week from Florida while their patients are coming to their clinic. So they still keep that continuity of care with their patients. So I think it's almost a case by case basis. And we're continuing to evaluate if that's some of the factors that we've considered.
Great. Thank you so much. And we're actually on our last question, and just in the nick of time. We have 3 minutes left. So the last question would be good to hear about the financial side. We are having trouble both in matching what makes sense for telehealth with what's reimbursed. For example, RN triage lines, for example, when RNs can't bill triage, and also the cost of transition, like equipment, training, patient outreach, tech support for patients and providers, etc.
So I think, for us, because we had the district grant for telehealth pre-COVID, it was, the purpose of that grant was to build the infrastructure that was necessary to support a comprehensive telehealth program within our organization. So because we had that, it helped us cover the cost of equipment and training, marketing, outreach, all the components that you've outlined in this question. We were fortunate to have that grant. And I think that's what's helped us set us up for success going into the pandemic. You are right that, triage lines, for an example, you can't bill for triage, but for us, when that went to a practitioner and it required evaluation and assessment, that was a telemedicine visit. That was a billable encounter at that point in time. So while there were some triages that stopped at triage and didn't require that, if it went on to a practitioner, we notified the patient in that moment that this would become a billable encounter and it would go to their insurance. They may or may not be subject to a copay or a deductible. It was actually in a smart phrase in the documentation for the practitioner. So, we billed at that moment. So there was value in that. And actually, that's a service that we do off hours. Many primary care organizations offer off hours call when somebody calls in, and we weren't billing for that before. This now has become part of our overnight call, whereas if a primary care practitioner gets a phone call and they are actually evaluating and treating a patient over the phone, it actually becomes a video visit, and that becomes a billable encounter. And we weren't doing that before with COVID. So we're finding ways of using telemedicine to bill for services that we were giving away for free before that are billable. And we are getting actual positive feedback from the patients and understanding that this, the services we are providing, they know it will be billed to their insurance. So you got to find that balance.
And I think, going back to my point of making sure you have finance as one of your stakeholders is imperative, because doing something that doesn't make money is not a good idea in healthcare. That's the world that we live in. And I think Deanna hit the nail right on the head. Is, you really got to take a look at it and kind of step back and see what your cost is going to be, how much you're going to be able to bill. Finding those things like where you're giving away care for free, those are the really good things to start your implementation of telehealth, because it's a positive all the time on the financial side. Rolling visits that the patient could come into telehealth just because it's convenient, those are the ones that finance is going to take a look at and say, how much are we getting reimbursed here? How much would we have been reimbursed if the patient came in? How many more visits can that patient, or then that practitioner who's driving an hour and a half each way, see? Does it balance out? But I think it's important to take a look at that with finance and see what the reimbursement scale is. And every payer is different. This is something else we didn't even touch on, but all of our payer contracts are completely different. So we can't just roll one thing out. We have to make sure it's okay with all of our payers, which just adds an extra wrinkle.
I saw somebody had an e-consult question. I don't know if we'll have time to answer that or not. We didn't touch on that one.
Yeah, touch on it
Yeah,
quick.
yes, so success at eConsults is quite innovative. Can you share some details on the history of reimbursement success with public and private insurance?
Go ahead, Deanna.
Okay. So, e-consults became billable, oh my goodness, I think it was mid last year, as a billable service. And so, in finding that out and trying to figure out how it would work for us, what we discovered, and I'm sure there's a lot of organizations, because we're rural, we have a shortage of specialty providers. So endocrinology, for an example, the days to a new patient visit were like 120 days to get into a new patient visit because we only had a couple endocrinologists. So we first looked at e-consults to leverage them to get real-time answers for our primary care practitioners of how to treat the patients and have a treatment plan from an endocrinologist without requiring a visit. So that's really where e-consults for us as an organization started. We built them out directly within Epic. There's questions that have to be answered and are required to be answered. Some were for billing purposes. Some were developed by each specialty and what they wanted to know. They receive it electronically in their in-basket, they review it, and they say, yes, I could treat this patient right now. I'll put in the treatment plan, I'll send it back to the primary care practitioner, or you know what, this I really need to see the patient in person for. They would shift that over to their schedule and get that patient scheduled in. So it helped getting people into specialty areas that were hard to gain access to, and allowed our primary care physicians to continue to treat their patients. We see a lot of utilization for this for our newer, what we call our APCs, so our newer nurse practitioners and physician's assistants who don't have years of experience and aren't comfortable making certain treatment recommendations without getting a consultation from a specialist. And so, and our specialists have also said there's a large percentage of patients that could be treated electronically in this method rather than bring them into clinic, so that we're saving room in the clinic for patients who really need to be seen in person. And Henry, I don't know if there's anything else you want to add.
Yeah, I think our reimbursement success that we've had, and we worked going back and forth with our coding department and finance department a lot with this, is, we get that 99441 when the practitioner reviews it on the specialty side, but we also, if appropriate, if our primary care practitioner spends more than 30 minutes explaining to the patient, gathering all that information that the specialist is going to want. And to be honest, it takes a lot of work off the specialist, because the specialist isn't, they're going, hey, I would get these labs, and if it comes back with this, I'd treat it with this. But then the primary care practitioner actually has to do that. So if the primary care practitioner spends more than 30 minutes on the care additional to what they normally would have spent by ordering these labs or imaging, any treatment that comes along with that, we're actually billing a 99358, which is a prolonged care code for 31 minutes or longer on the primary care side. So it's actually been a very successful program from the finance side. Our patients love it, our primary care practitioners love it, and our specialists that we've got on board also love it. So it's been a win-win all around for our organization.
And patients don't have to travel to a specialist because we are so rural. They appreciate not having to travel, but they also get a copy of the note. That is something we do. So they receive a copy of that consultation from the specialist directly into their mind chart. And if they don't have my chart, we mail it to them so that they know it actually occurred and what the treatment plan recommendations were from that specialist.
Wow, Dina and Henry, I really would like to thank you for your presentation today and being so active and answering the questions. Wanted to remind the audience to please leave feedback for our speakers in your session feedback within the app. Also, I think right now we're taking time for a stretch break to prepare for the next session. So really want to thank folks for sticking around. I think we had close to 30 people on this session. So thank you so much for your interest, and we look forward to seeing you for the rest of the conference. Have a great day, everyone. Thank you.
Thank you.
Thank you.